The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/QUE860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, and welcome to Mapping the New Era in CLL Management, Precision Medicine and Patient Perspectives in Treatment-Naive and Relapsed Disease. I'm Professor John Gribben from Bart's Cancer Institute, Queen Mary University of London. Today, I'm joined by my colleagues, Dr. Ryan Jacobs from the Levine Cancer Institute in North Carolina, Dr. Alessandra Tedeschi from the LaGuardia Cancer Center in Italy, and Dr. Philip Thompson from the MD Anderson Cancer Center in Houston. I'm also pleased to welcome Terry Evans to our panel. He is a CLL patient and advocate representing our collaborative partner, the CLL Society. So today's agenda, we're going to have some seminars and tumour board sessions, seminars on major trials validating novel targeted approaches in a range of CLL patient populations, and tumour board style case discussions on making modern therapeutic choices in treatment-naive and relapsed/refractory CLL. Then we have a final seminar on the next wave of advances in CLL, targeted combinations, MRD assessment, and CAR T cells. Moving now straight on to our seminars and tumour board session, I'm going to hand you over to my colleague Alessandra Tedeschi, who's going to take you through innovative therapeutics in treatment-naive CLL. Alessandra, over to you.
Thanks, John, and thanks for the kind invitation to this meeting. Let's start with the first case. Bill is a 72 years old patient in whom a CLL diagnosis was performed at the age of 69, and after 3 years he is in need of treatment for anemia with an hemoglobin level of 9.2, and he presents with lateral cervical and abdominal adenopathies, maximum 6 centimeters. He has an ECOG performance status of 1, a creatine clearance of 58, and as comorbidities we have recorded hypertension, were controlled with 1 medication, and diabetes controlled by oral therapy. Before starting treatment, we performed FISH analysis showing a 13q deletion. Patient was TP53 wild type and unmutated HHV. So we are in front of an elderly patient, unmutated, no 70p deletion, TP53 wild type. With the many opportunities we have with the target therapies, the question in this moment is there is still a role of immunochemotherapy in this patient. And I think that has been well clarified by all the trials with immunochemotherapy that unmutated patients are those with the shorter survival, progression-free survival when treated with immunochemotherapy, even with a more intensive treatment like FCR or BR, and this is more true in the elderly treated with chlorambucil obinutuzumab. On the other hand, we have novel options. All of these are approved regimens for patients in first line. We have the opportunity to treat our patients with continuous BTK treatment, such as ibrutinib or acalabrutinib in monotherapy or in combination with anti-CD20 monoclonal antibodies. Or, on the other hand, we have fixed duration treatment with the BCL2 inhibitor venetoclax in combination with obinutuzumab. Ibrutinib monotherapy was first used in these phase 1-2 trials, and we have now the longest follow-up of these 31 elderly patients treated in first line Progression-free survival median progression-free survival has not been achieved after follow-up up to 8 years, and the estimated 7-year progression-free survival is of 83%. Our patient was an elderly patient, so let's focus now on ibrutinib randomized trials addressed to the elderly population. We have 3 trials. The first one is the RESONATE trial, where patients over 70 years or between 65 and 70 years were randomized to receive ibrutinib or coramucil. In the ILLUMINATE trial, elderly patients or those with coexisting conditions were randomized to receive ibrutinib in combination with obinutuzumab or compared to obinutuzumab coramucil. And then we have the Alliance study, in which I would say elderly but more fit patients were enrolled, because the comparator arm was represented by bendamustine rituximab, and patients were randomized also to receive ibrutinib monotherapy or ibrutinib rituximab. In all the 3 trials, we can see an improved and significant prolonged progression-free survival for patients treated with ibrutinib-based therapy. This is true for the first trial, in which now we have a follow-up of 5 years, and you can see a progression-free survival rate at 60 months of 70%. And in also true for the Alliance trial, in which ibrutinib was compared to a more intensive treatment like bendamustine rituximab, and at the first follow-up at 24 months, we have a progression-free survival rate of 87% versus 74%. And should be outlined that there was no difference in outcome when patients were treated with the combination ibrutinib rituximab versus ibrutinib monotherapy. Our patient was unmutated, so if we look at the outcome of unmutated patients in these 3 trials, we can see that there is a significant difference in unmutated patients in the RESONATE 2 trial and the ILLUMINATE trial in favor of ibrutinib treatment, while in the Alliance trial at 24 months there is no significant difference, although the median progression-free survival has been achieved for patients treated with bendamustine rituximab at a median of 39 months. Maybe the follow-up of this trial is too short, because, as we said, in this trial, bendamustine rituximab may give a better disease control. Acalabrutinib is a second-generation BTK inhibitor with less effects on the other kinases in vitro. Those are the first patients treated in first line with acalabrutinib, 99 patients, and now we have a follow-up of 53 months. Event-free survival at 48 months is of 90%. ELEVATE is the trial that brought to acalabrutinib approval, both in monotherapy and in combination with obinutuzumab. The trial was directed to elderly patients more than 65 years or patients with comorbidities. And then the patients were randomized to receive acalabrutinib monotherapy, acalabrutinib in combination with obinutuzumab, and compared again with chloramucil obinutuzumab. We can see at 24 months a significant longer progression-free survival on patients treated with a BTK inhibitor. And a post-hoc analysis demonstrated that there may be a role of adding obinutuzumab to acalabrutinib, as hazard ratio for progression-free survival between acalabrutinib obinutuzumab and acalabrutinib monotherapy was 0.39. Again, if you look at the outcome of our unmutated patients, we can see a significant longer progression-free survival, 91% at 24 months for patients treated with the BTK inhibitor versus 33% in patients treated with immunochemotherapy. If we look at the possibility of treatment with a fixed duration venetoclax, the rationale under this regimen is that with venetoclax we may achieve profound and deep responses. So venetoclax for 12 months was added to obinutuzumab in the CLL 14 trial, which was designed for patients with a CIRS greater than 6 or a creatinine clearance less than 70. As we can see here, in the second follow-up of the study, an important prolonged progression-free survival for patients treated with venetoclax or inotuzumab were compared to chlorambucil or inotuzumab at 36 months, 82% versus 50%. The same benefit applies when we consider only unmutated patients in whom inotuzumab chlorambucil led to a median progression-free survival of 26 months and not reached for venetoclax or inotuzumab patients. Now, the question is, does age matter in front of an unmutated patient? We have here a similar patient, Mark. He is 62 years. He is a fit patient without comorbidities, normal creatinine clearance, and has absolutely the same characteristics of Bill, IAG3 unmutated status and TP53 wild type. All the regimens we have seen before have been approved for adult patients treatment naive, and we have here a trial addressed to the fit population, less than 70 years, and more fit patients because the comparator arm was represented by FCR. This is the ECOG trial in which patients were randomized to receive ibrutinib plus rituximab versus FCR, and we can see even in this trial a better progression-free survival when compared to FCR for patients treated with ibrutinib, with a 3-year rate of 89 versus 71%, and the benefit was also observed in the unmutated population with a 3 years progression-free survival rate for patients treated with ibrutinib of 89%. Let's so go back to our first case. Was Bill, who was an unfit patient, and for sure we don't need in these patients immunochemotherapy. As we have seen with immunochemotherapy, we have a shorter progression-free survival, and we have many options with target treatments. What do you think, John, would be the better?
Yeah, thanks, Alessandra. Clearly, you've presented a very strong case in these unmutated patients for the use of novel agents. So let's bring Terry into to this discussion, because of course that is exactly what we would do in the clinic if having these conversations, we're bringing the patients in and talking about the choices and explaining the rationale. So Terry, in terms of as a patient perspective, how important do you think it is that patients are informed about things like their mutational status, the mutational status of things like TP53, and how is that in the modern era? How would you like to see that factored into the discussions with our patients?
Well, I think in the beginning when patients are facing maybe their first treatment, there's probably a great misunderstanding of what all of the markers mean, what the options are for patients in the long term. And I think that really needs to be discussed with patients in terms of, the longevity of the treatment, how long it's going to last, not only during therapy, but also after the fact. And, if you go to immunochemotherapy, what are the risks of that long term? Certainly I think there's shown that certain classes of patients probably shouldn't qualify for chemoimmunotherapy and would be directed to, the newer targeted agents. But even those have issues associated with them, continuing treatment on the BTK side and maybe a fixed duration treatment on the BCL2 side. So I think the important thing is to explain to the patients exactly what they're facing in terms of maybe future treatments, because many CLL patients relapse after their first treatment. So we always tell people in the support groups that, the choice of their first treatment is really a key decision that they need to make, and they need to be completely informed about not only how that's going to affect them during the actual treatment, but also what the long-term ramifications are that if and when they do relapse and deciding on what's next.
I can't agree with you more, Terry. I mean, we've known for a long time about the prognostic significance of the mutational status of the immunoglobulin genes. Lots of my patients want to know it at diagnosis to give us a clue as to how long they might go without requiring any treatment. Of course, most people ask for it to be done, hoping and expecting they're going to be mutated, and then are disappointed to find that they're unmutated. But here, what Alessandra's shown you is the data about why it's now predictive. That is telling us how well you're going to do with a particular type of treatment. And once we have this type of data, it's gone from a tool which gives useful information but might not have been available in every centre to a test which is now, of course, giving us information about the ideal treatment, as Alessandra has taken you through. And of course, the IWCLL guidance now actually state that immunoglobulin mutational status is an essential component of the workup of a patient at the time of treatment, because it is informing us as to the right form of treatment to go on to. So Alessandra, why don't I hand you back to you and we can go on and discuss your next cases, and then come back and think about how these things factor together when we see other pieces of data.
Here we are in front of Susan. She is 63 years old. She needs of treatment for anemia and thrombocytopenia. She presents with splenomegaly, 18 centimeters, and small adenopathies of about 3 centimeters. Our patient is a fit patient. She has an ECOG performance status of 1, creatinine clearance of 71, and no comorbidities. She has a diverticulosis, but she is managed with occasional antibiotics. FISH trisomy 12, the TP53 is wild type, and she is a mutated patient. So if we look at how many patients like this we have in our clinical practice, patients with these characteristics are very rare, I would say, in about 10%, because we know that CLL is a disease of the elderly, and most patients are treated when they are more than 70 years and they are unmutated. We can argue again if there is a role of immunochemotherapy in a patient like this. And the German study and the MD Anderson long-term follow-up studies with FCR demonstrated a prolonged progression-free survival and overall survival in this patient treated with FCR, with a plateau at the end of follow-up. These are the results of an Italian study where patients with favorable characteristics, no 11q deletion, no 70p deletion, and a mutated IGHV were considered, and we observed that after FCR, these patients may achieve an overall survival which is similar to the general population aged for age, matched for age and sex. So, if we refer to the ECOG study, which is, as we said, the study addressed to the younger population, we can see that in the mutated patients, there is no difference between FCR and ibrutinib continuous treatment plus rituximab in terms of progression-free survival. But again, if we look at the mutated patients in the randomized trials addressed to the elderly, we can see that ibrutinib therapy was associated with an improved progression-free survival in the RESONATE 2 and the ILLUMINA trial, and this was more true in the RESONATE trial, maybe because chlorambucil does not exert a great disease control. But again, in the Alliance study, there was not a difference between patients treated with a BTK inhibitor or BR when we look at the population of mutated patients. In the ELEVATE trial, at 24 months, we have a longer progression-free survival in patients treated with acalabrutinib obinutuzumab when compared to chlorambucil obinutuzumab. And if we look at the patients treated with the fixed dose venetoclax-obinutuzumab regimen, while in the first follow-up of the study at 24 months, there was no difference on progression-free survival in mutated patients. Now, with a longer follow-up at 36 months, we can see a clear separation of the curves. Now, the question is, what should we do in a patient mutated, in this case was a fit patient, but we can put together considerations for the also elderly population.
So very good point, Alessandro. So here, of course, we have some choices and some options. This patient, of course, would be eligible for FCR on the basis of the data you've shown me. Could be a very good option and might be that group of patients in whom chemoimmunotherapy might even, in a group of these patients, be able to offer a curative approach. Clearly, we did not see a difference in the outcome in the ECOG trial between these mutated patients between FCR and ibrutinib, but that also means, of course, that ibrutinib at the present time was not inferior to FCR, although I think many of us feel this group is going to need much longer follow-up. And then this is a group of patients who also have done well with venetoclax plus obinutuzumab. Now, of course, the CLL14 trial enrolled patients who were elderly and had comorbidities, but of course the licensing approval is for any patients. So here then, if I can bring back in Terry, this is a case where you might be being met then and told by your doctor here, Terry, that you have three potential options. One, some quite aggressive chemotherapy, which might give you a difficult period to come through, but a fixed duration therapy with a potentially very good, very long-term outcome. Ibrutinib, which we might also have considered, or acalabrutinib, which you might also have considered if you were mutated or unmutated, and now also a fixed duration therapy with venetoclax obinutuzumab. So from a patient's perspective, Terry, what kind of information are you looking for we as physicians to be providing to you as a patient to help you make these sorts of decisions?
Well, I think that, clearly the long-term data for FCR and BR is out there for the patients to see. I think given a certain set of patients, they respond very well, almost to the point of saying, it perhaps is a cure. So I think that needs to be presented as an option to patients so they know that there is that possibility. On the other hand, if they relapse after it, are they going to be angry? Well, you said I had a really good chance of, of this lasting a long time, and I went through, this treatment, and now it's coming back. But I think, when they enter into the treatments, they've got to look at all the data. Some people, I think, hear the word, chemotherapy, and they get deathly afraid, and may be more directed towards a BTK inhibitor or a BCL2 inhibitor. In the case of the BCL2 inhibitors, you potentially have also a fixed duration treatment. And so I think that, you have to think about this and what you're comfortable with, and, what the doctor's experience is with all three of the regimens. I think that's really important to know that your physician has experience with all the treatments that they're going to present to you, and know the potential risks and the outcomes of those. And I think, certainly, there's been, a lot of data historically on acalabrutinib and ibrutinib that you can have a very long period without disease, or at least stable disease. And some people don't object to taking, an oral drug for 4, 5, 6 years, and it's not that big a deal to them after a while.
Let me bring Phil into this discussion, because of course the MD Anderson were the first to describe, in fact, Phil, you were the first author on the paper, showing us this plateau of appearance on the FCR treatment. So what's your approach now to a younger patient who's FCR eligible in terms of them kind of wanting to be thinking about using chemo-free regimens instead?
Yeah, I mean, it's a really good question. So in this patient, I would look at her and I would say, okay, with FCR, she has a median progression-free survival of more than 10 years and possible cure. And, you know, that's sort of based on her genomics and the fact that she's likely to tolerate treatment reasonably well at her age. Similarly, though we're seeing excellent results for these patients with targeted therapies, I guess when you're looking at someone who may have a median progression-free survival of 10 years plus with a treatment that takes 6 months or 12 months compared to having to take 10 years of maintenance therapy with a BTK inhibitor to achieve the same results, you know, you certainly have to factor that in. We think about the side effects of chemoimmunotherapy, but taking a BTK inhibitor for 10 years is not necessarily without side effects. So, you know, we see in the long term high incidence of hypertension, we see cardiac arrhythmias, we see bleeding. So these are important discussions to have. I think one thing that we're getting from studies of time-limited therapies is, and we'll discuss this later in the symposium, is looking at MRD results. And I think when you look at the MRD rates, the rates of undetectable MRD after FCR, and then you look at the rates of undetectable MRD after, say, obinutuzumab and venetoclax, you're seeing better probably rates of undetectable MRD with venetoclax-based therapy frontline than you are with FCR. So the question then becomes, will we see long-term results with targeted therapies, venetoclax or obinutuzumab, that maybe even exceed that we see with chemoimmunotherapy? So my approach with you know, to this patient, you know, certainly she would be a candidate for FCR, but I would discuss with her maybe your outcome will be similarly favorable or even better if we gave you obinutuzumab and venetoclax, which is a chemotherapy approach, which with of course the big caveat that we don't have the long-term follow-up results from that study yet. And then I would say, well, you know, you have those options. Probably you'll do very well with a BTK inhibitor long term, but of course you'll have to take long-term therapy, and you know, intolerance can become an issue.
Yes, also, Phil, the younger the patient is, the more you're talking about lifelong therapy being very, very long indeed, and sometimes then the easier it is to be thinking more in terms of either the fixed duration therapies in that particular setting.
Yeah, exactly.
So let's keep on moving on, because of course what we're hearing is of course choices that we have based upon the outcome of these markers. So let's look again at what we see. Alessandra, back to you.
So we have focused as for now on progression-free survival, but also we have to look at overall survival. And no significant overall survival differences were observed in the Alliance and Luminate studies with ibrutinib on the Elevate study with acalabrutinib, and this may be related to the short follow-up, but also to the confounding of crossover in these studies. The improvement in overall survival in patients treated with ibrutinib was observed in the RESONATE-2 trial, maybe because the comparator arm in this study was represented by chloramucil that did not exert disease control, and we had also an improvement in overall survival in the ECOG trial, in which patients in the comparator arm received FCR and there were an excess of death due to FCR toxicity.
How much, Alessandra, do you feel that overall survival differences really make you change your mind about the way you treat people compared to progression-free survival differences, irrespective of how much those differences might be in these trials?
I believe that, of course, ibrutinib is better than chloramucil, and what this study demonstrated is that even in the elderly population, we need to exert an immediate disease control. Otherwise, in this study, crossover was allowed, but at the end we didn't salvage patients with ibrutinib, and maybe because the characteristics of the patients didn't allow us for metabolic conditions and so on to give ibrutinib salvage treatment. And what is impressive when I see the ECOG study, and in this moment in Italy we are treating patients mutated and young patients with FCR, but it's impressive to see a difference in overall survival. So sometimes I ask myself if it's ethical to suggest FCR to a young patient when I have a difference in overall survival in any case.
The other thing I take from this, of course, I, unlike you, young people, grew up in an era where trial after trial that showed progression-free survival did not translate into overall survival differences. And I still heard people saying, oh, we should keep the better drugs for later, for when the patient relapses. But what we're seeing over and over again is the very best outcome coming from us using our very best treatments right up front in these patients. And you can't, of course, capture a patient back with whatever good your salvage treatment is if they've already had a death, as we saw, for instance, in the ECOG trial. So I think it makes us have to think very seriously about what we're talking about now, which is the frontline treatment, but also be thinking about the whole sequence of treatments for our patients. And I know we're going to come back and be discussing that later.
We have here another patient. He is Christian, and he has 71 years old. His needs of treatment for thrombocytopenia, splenomegaly, and abdominal adenopathies of 4 centimeters. The patient has an ECOG performance status of 1, a creatinine clearance of 53, and now we are in front of a patient with a 70p deletion, TP53 mutation, and unmutated IGHV. He has as comorbidities a well-controlled hypertension and aspirin treatment in the last 2 years for a transient ischemic attack. If we look at the ibrutinib trials, both Illuminate and Alliance trials enrolled a small proportion of patients with a TP53 mutation or 70p deletion, and progression-free survival was clearly in favor of patients treated with a BTK inhibitor. If we want to know what happens to our population in first line, we can refer to this phase 2 study in which only patients with a TP53 aberration were enrolled, and has now a follow-up of 6.5 years. And we can see at 6 years a progression-free survival of 61%, and importantly an overall survival rate of 79%. Even in the 11th trial at 24 months, progression-free survival was in favor of patients treated with acalabrutinib or acalabrutinib obinutuzumab. And if we look at the fixed duration treatment, venetoclax obinutuzumab, we can see a significant difference even in patients treated with venetoclax obinutuzumab compared to chlorambucil obinutuzumab. But then, if we stratify patients treated with venetoclax obinutuzumab according to the presence or not of TP53 mutation, we can see that at 24 months, progression-free survival in patients carrying TP53 mutation was shorter, a rate about 70%. So it's clear that these patients should receive a target treatment. Now the question is continuous treatment with BTK or a fixed duration treatment.
Okay, so let's bring Terry back in again for discussion here. Terry, I have to admit, when I do all of these markers on my patient, the one that I'm always hoping not to have to tell people that they have is the TP53 mutation, which of course used to be such a setting in which we had very little treatments available. So you're now in putting yourself in the position, Terry, of being told now that you have this TP53 mutation. I think the data here is quite clear that chemoimmunotherapy is not a treatment choice, but we have, at least we're very thankful to say, we have 2 good classes of drugs that work in the setting of TP53 mutation. And you've just seen the data looking at ibrutinib or acalabrutinib as examples of the BTK inhibitors for continuous therapy versus the data we already have for venetoclax obinutuzumab in the setting here of giving a 1-year fixed duration, a bit of a suggestion that perhaps the 17P patient's not doing quite so well. I'm using 17P patients here as a shortcut for talking about either mutation or deletion. So what are the factors here, Terry, that come into play, and what are you as a patient thinking about when you're hearing and seeing this data?
Well, I think you're right. I think TP53 presents a challenge to patients, and I really think a patient should look at the outcomes of the newer classes of drugs. More than likely, chemoimmunotherapy is completely off the table at this point in time, and so you have to look at one of the newer targeted therapies. It would be nice to have longer-term data on some of them, but clearly the data shows that it appears to be almost agnostic with the newer data as if you do have TP53, and there are very good responses for both of them. I think, again, a patient's choice of do you want to be on a continuous therapy, or we have a limited fixed duration therapy that we can give you, and the responses are seemingly very good in that environment. So I think maybe those are the two choices that patients should look at. Certainly the BTKs have got a little bit more data, a little bit more history on them, and we don't know the long-term data of the BCL2s yet, but the data that we do have seems to be pointing very favorably to a longer term, especially if you get to MRDU, that is really a good sign, which is something that usually most patients don't get to with the BTKs, but they do get stable disease, which is really important, I think, for patients to know about, that they can get to stable disease. And so it might just come down to, do you want continuous therapy of one of the newer therapies, or do you want more of a fixed duration therapy? This data over time may change, I think, what the treatments are recommended for these patients. So, and looking at comorbidities and what are the things the person has going on. And I noticed that, they're under aspirin treatment. And so is the thinning of the blood an issue with the BTKs? I mean, I think you have to at least acknowledge that and put that into the equation when you do choose the treatment.
Yeah, so that's something we haven't focused on enormously here in terms, and something that certainly Phil brought up in his discussion earlier on in the other case, was weighing up all the benefits, of course, but also thinking about the potential toxicities associated with treatments. So Alessandra, this is your case. So looking at the data that you've presented, what would be your choice to treat this patient here?
I believe that in this moment we have more consistent data with continuous treatment with BTK inhibitors. Of course, venetoclax obinutuzumab showed to be effective, but during follow-up we have a clear separation of progression-free survival course. Of course, venetoclax may give us the possibility to retreat patients with venetoclax, but these are all data that we will have in the next future, I would say, because we don't have retreated patients in first line with venetoclax again. So as for now, I would prefer a continuous treatment in a 17P deleted patient.
Yeah, it would be good to have data looking at continuous venetoclax in this setting also, but in the frontline setting, we're not yet have it. As I said already, I'm very pleased that we do have two classes of drugs that at least work in this setting. In the CLL field, of course, we're lucky, is that the frequency of TP53 abnormalities in non-Hodgkin's lymphoma, in leukemia, and other settings, not too dissimilar, but in those other diseases, there's not yet specific treatments targeted to this patient group. And of course, this is a patient in the not too distant past. We would potentially even at 71 be thinking about whether they even fit for an allogeneic stem cell transplant as our treatment approach. So we should be very grateful and thankful that we have the agents available that we do. Anyway, we've still got lots to get through, so Alessandra, why don't I hand back to you?
So the treatment paradigm has changed in CLL. Historically, we used the fixed immunochemotherapy duration treatment. Now we have the possibility to treat our patients with continuous treatment with BTK inhibitors, acalabrutinib and ibrutinib, and the goal of therapy is here disease control, and we may achieve a prolonged progression-free survival, and this is independent from response. So we know that the quality of response, a complete remission rate, although it's better over time during ibrutinib treatment, we don't exceed the 30% at 6 years, and we can speak about undetectable MRD only if we add obinutuzumab. On the other hand, we have fixed duration venetoclax obinutuzumab. We have here prolonged progression-free survival because we may reach disease eradication with undetectable MRD. We will speak about MRD later on. But you can see that at the end of treatment, undetectable MRD is high, 76%, and this translates in the prolonged progression-free survival and prolonged overall survival. Of course, we have also to consider safety. If we look at the trials with ibrutinib, we can see that primary reason for discontinuation was more frequent for adverse events, accounting for the 20% in all the trials, and this may be higher in practical clinical practice because of comorbidities of patients. A very low rate of progressive disease during treatment. The most important adverse events of grade 3 decrease over time. We have a prevalence that decrease over time apart hypertension. And of course, as we are speaking about BTK inhibitors, we have to focus on adverse events of interest such as atrial fibrillation. And in the trial with the longest follow-up addressed to the elderly, the rate was of 16%. Major hemorrhages decrease over time, and then we have to consider also long-term hypertension. As regards acalabrutinib, we can see that in the phase 1-2 study, which is the one with the longest follow-up, discontinuation rate for adverse events was of 6%. In the ELEVATE trial with a follow-up of about 28 months, we have a discontinuation rate of about 10%. We have to remember that acalabrutinib has a specific side effect, which is a headache, normally of grade 1-2, and normally is transient. Always is a BTK inhibitor, so we have to focus on adverse events of interest. Atrial fibrillation is of about 3-4% after a follow-up of 28 months. Low rate of major bleeding and a low rate of grade 3 hypertension. And finally, venetoclax obinutuzumab, it was very well tolerated even in a population with a high SIRS score. The most frequent adverse event of grade 3 and greater was neutropenia, 52%, and neutropenia was also the most common cause for discontinuation or dose reduction, accounting for 16% and 20% of patients respectively. In conclusion, we can say that target therapy has changed the treatment paradigm in CLL. In all the randomized trials, we observed a progression-free survival benefit in the experimental arm, that is ibrutinib monotherapy or in combination with rituximab or obinutuzumab, or acalabrutinib monotherapy or in combination with obinutuzumab, and fixed duration venetoclax obinutuzumab. The major benefit has been observed in high-risk patients, those with 70p deletion, TP53 mutation, and unmutated IGHV. And target therapy was well tolerated in all trials, even in patients with coexisting comorbidities, and no new safety signals were recorded with prolonged follow-up. Treatment choice, of course, depends on patients' characteristics, disease characteristics, and as we said, on patient preference. Thanks for the attention.
Well, thanks, Alessandra. Wonderful summary and great to put it together in cases and great to have Terry's input into it. And of course, this weekend at ASH, we're going to be seeing more of the further follow-up that we've all been asking for. And of course, as part of that, we're always looking to see what would be the kind of emerging side effects. As you've said already, no emerging side effects with the targeted therapies so far, Alessandra. But of course, at each ASH meeting, one of the things I'm always looking forward to seeing is not just the further progression-free survival follow-up, but to make sure that there are no later adverse events seeing. So we've already got questions coming in from the audience. I think this is a good time to stop just for a couple of questions here. We don't have time, unfortunately, to take too many, but let's bring in everyone to be thinking about this. Of course, this is the year of COVID. During COVID, what's our view about FCR versus ibrutinib-based regimens? Phil, why don't I bring you in on that one first?
That's a really good question. So we've seen some data come out from some early case series of CLL patients that got COVID that suggested that maybe patients on targeted therapies, particularly BTK inhibitors, might have had better outcomes than those who had recently had chemoimmunotherapy, or indeed patients who were not actively being treated. So there are many things we don't know about COVID, including to what extent immunosuppression leads to worse outcomes, to what extent the immune system is responsible for a lot of the negative outcomes in the disease. But my approach is generally to be trying to avoid chemotherapy and perhaps CD20 antibodies unless you really feel that they're strongly indicated in that particular patient. So in this situation, I think also with BTK inhibitors compared to other therapies during COVID, it's a bit more of a low-touch therapy. You don't perhaps need to see the patients as often in the clinic and check labs as often. So for a number of reasons, I think that BTK inhibitors are preferable in countries where there's high incidence of COVID at the moment.
I'd love to bring you all into this, but I think we need to move on to the next question. So someone asking here about, given how effective these therapies are, should younger patients ever be watch and wait? Should we not just be treating at diagnosis? So Ryan, what's your thought on this one?
Yeah, thank you. So there is some, I know, research ongoing looking at particularly the high-risk patients, the patients with 17p aberrations that maybe are not symptomatic, and whether starting treatment early with a novel agent such as a BTK inhibitor, whether that seems to improve outcomes. That data has not reported out yet to a degree that has led us to change how we've been managing asymptomatic CLL patients that are not exhibiting any criteria for treatment, and just at this time we have no data to motivate us to start treatment early at this point. So even in 2020, with all these great options for symptomatic patients, the rule for those patients that are asymptomatic at presentation is still to continue the watch and wait approach.
Yeah, I completely agree. I mean, we'll get data from the CLL-12 trial, among others, and at least these trials are ongoing. And we've only seen, all we know on that trial so far is that all of the patients that were on watch and wait have now moved on to, in that case, ibrutinib treatment. So we'll get it. But of course, it may be a very long readout on that trial. And you're absolutely right. We should continue to watch patients meantime. Then we've got a whole series of questions asking us about, the venetoclax BTK combinations. And that's such a good question. We've kind of preempted that, and we're going to be talking about that later. So I think let's just move on and hold those questions for the meantime, because we will be addressing it and we'll come back to talk about it later. So Ryan, why don't I hand over to you to be talking about treatment sequencing?
All right. And thank you again, Dr. Gribben. We will move on here. And as mentioned, we're going to focus on the treatment of relapsed CLL here, and I probably can make up a bit of time in this discussion as we're going to be focusing mainly on novel therapies, as those, as I'll show you, appear to be the most effective treatment interventions for patients with relapsed CLL, it seems. So let's start out with a patient presentation, as we've done. Thomas here is a 74-year-old male. He was diagnosed in CLL back in 2014, made it a couple of years on observation. His prognostic workup revealed a FISH that was positive for trisomy 12, and he was unmutated at the IGHV gene. He got treated with BR back in 2016, and now during follow-up he has increasing fatigue, adenopathy that is painful at 4 centimeters. Notably, repeat prognostic workup is done as is appropriate, and shows no new FISH findings. His lab work shows there that he is anemic significantly and getting progressively thrombocytopenic. So this patient, Thomas, has several indications for treatment in the relapse setting after making it about 4 years after receiving BR. So the question is, what should this patient now receive who's received prior chemoimmunotherapy and needs treatment in the relapse setting? And Dr. Gribben, I'll turn it back over to you to get your thoughts.
Okay, so let's think about this. So we've got a patient relapsing some. How long did you say after his treatment, after his BR? Oh, 2016.
So he's been 4 years.
So we clearly have some clinical trial data that we're going to be going into and think about. We've got evidence from BTK inhibitors. We've got evidence from venetoclax. Terry, from a patient's perspective, once a patient kind of relapses in the setting, what kind of information are patients looking for to be making informed decisions about how it would be the best form of treatment for them at second line?
Well, I think a patient has to look at what the data is. Certainly, a treatment-naive patient's situation is a little bit different than relapse refractory, and now at least there are several options available to patients. I think again you're talking about really a continuous treatment using a BTK or using a fixed duration of a BCL2. So I think those have to be presented to the patients and asking them, what their, maybe preferences are in this. Maybe if there's data that shows that coming off of a immunochemotherapy treatment, the responses are better. It doesn't seem like they've got any issues with TP53. So I think we talk about this in our support groups that now CLL patients have a variety of options available to them now, and some of this patient has to look at long-term data, but maybe also the physician's experience with these drugs and maybe giving their opinion and input on which one may be better, and also looking at on the BCL2 inhibitor, is there going to be a fixed duration based on MRD status, and is it fixed duration based on months, or is it based on MRD status when we actually would stop that treatment? So I think those are the types of questions that you have to ask your medical team.
So Ryan, I know you're going to take us through the guidelines, and we're talking here about a patient, and certainly some people would consider that you could go back to chemotherapy, but my own view is that the clinical trial data that you're going to take us through really would be much more in keeping of there's really virtually no role for chemoimmunotherapy in the relapse setting, and we should be thinking about the novel agents. So I'll hand back to you.
Yeah, and I completely agree. I was just going to segue into putting up the NCCN guidelines for the different subpopulations of relapsed CLL patients, and you can see here that targeted agents, particularly the category 1s with the agents that we've discussed extensively so far with BTK inhibitors and BCL2 inhibitor, venetoclax, are what are put in the preferred regimens for CLL patients that are having a recurrent disease, and this is really regardless of age and comorbidity status. And chemotherapy really has been pushed to category 2 and below, and I would agree with you that there really is no clear role for chemotherapy any longer. And I would really agree with the point that Terry made as well, that with our growing number of options and presenting the data, some of which we've discussed already, to our CLL patients, it's really important not to get lost in presenting all that data to a patient who's not in most circumstances received extensive medical training, and make sure and give our own opinion, because ultimately the patients are obviously very interested in with all the data that's out there, what we would ultimately recommend. And so I'm going to try to present a lot of that data for the relapsed CLL patient population to try to help guide us in treatment decisions in the relapse setting. This PCYC 1102 study was presented earlier, focusing on the frontline PFS curve. I am going to focus here on the relapsed refractory curve here, where you see that we have reached a median with 52 months, which is far superior to anything that chemotherapy was doing previously. As I'll show you later, when bendamustine is used in comparator arms in the relapse setting, we often get 1 to 2 years maybe progression-free survival. So for long-term follow-up data with ibrutinib in the relapse setting showing 52 months, this was a big breakthrough for CLL patients as an option back, I know in the United States in 2014, when ibrutinib was first approved for treating relapsed CLL patients. And all those changes that we've seen in those NCCN recommendations and how we're managing relapsed CLL patients have occurred in just that short period of time. So it's really a remarkable change. It appears like in the frontline setting, the similar story for relapsed patients in terms of outcomes by subgroup analysis. The 17p patients, while doing better with novel targeted agents, the other subgroups, for example, deletion 11q, IGHV unmutated, while there might be some visual separations in these PFS curves to a statistically significant difference, it remains just 17p deleted patients, TP53 mutated patients, that are doing worse to a degree that's statistically significant on long-term follow-up. Of course, prospective data is nice. We are always interested in what's happening out in the real world. This is a Connect CLL registry data that is looking at that important question of overall survival, where we have patients like our patient here that was treated with chemoimmunotherapy. This included both FCR and BR, and then on close to 1,500 patients, they looked at whether these patients got ibrutinib as a second-line agent or got additional chemoimmunotherapy, and you can see with a really significant hazard ratio for overall survival at 0.46 that the risk of dying is essentially reduced by over 50% when ibrutinib was chosen as the second-line option compared to additional chemoimmunotherapy. So that certainly is motivating and informative on this treatment decision that we're discussing with this patient. So discussed ibrutinib. What about acalabrutinib? Again, similar long-term follow-up data showing 17p patients overall doing worse, but the rest of the high-risk subgroups, for example, deletion 11q, seem to be doing very well long-term on acalabrutinib. I have the benefit of not needing to spend as much time discussing toxicities because they've already been discussed on the frontline portion of this this talk, the nice thing is with our targeted agents, there doesn't appear to be big difference in toxicity profiles, whether the drugs are used in the frontline or relapse setting in terms of the symptomatic toxicities. With ibrutinib, I just like to highlight that there appears to be only one toxicity that is cumulative over time, and that's the hypertension that you see here, where the incidence grade 3 plus does seem to go up year over year to a degree. The other toxicities do go down, so I really try to coach my patients if they're dealing with toxicities early on in therapy that there is reason to hope that those toxicities will improve over time, and there is a degree of acclimation that appears to occur. And that seems to be also true with acalabrutinib, as you can see here. And acalabrutinib, because of perhaps its reduced effects on the cardiovascular systems in terms of off-target toxicity, you don't necessarily see that cumulative build over time with the hypertension. So really across the board with acalabrutinib, most notably that headache that was previously mentioned does seem to go down over time as well. So patients, the longer they're on the drug, the less likely that they are going to have to come off due to significant toxicity. What about the phase 3 data? We've been talking about earlier phase data for longer follow-up. Let's look at the larger studies. So, of course, the RESONATE study was the study I alluded to earlier that led to ibrutinib's approval back in 2014 in treating relapsed CLL patients. You can see with the long-term follow-up, both PFS and overall survival show improvements here with using ibrutinib, and I don't think many of us are surprised with that long-term follow-up data to see those results. Subgroup analysis shows that all subgroups that were looked at, including these of notable interest that were high risk, do appear to favor the ibrutinib arm. So it's not just the high-risk patients. And as potentially, we have been debating in the frontline setting that whether or not you should think about chemo versus novel agents, whether they're mutated or unmutated. Really, all of the subgroups appear to be doing better with targeted agents in the relapsed setting. Again, flipping back to acalabrutinib, discussing the phase 3 data, we've got the ASCEND study that interestingly had two regimens that it was compared to with bendamustine rituximab or idelalisib with rituximab, and that was up to the investigator. So large trial looked at progression-free survival as its primary endpoint, and as illustrated here, again, showed statistically significant superiority in progression-free survival when compared to either BR or idelalisib. What's notable about this study is whether it's in the front line, whether it's in the relapse setting, at this time we don't have a lot of head-to-head data comparing these novel agents, particularly comparing using BTK inhibitor versus a BCL2 inhibitor. Idelalisib is one of the novel agents that have been approved since 2014. Of course, it's a PI3 kinase inhibitor. We have not been using this agent as much because of toxicity issues, but here we can also see to a statistically significant degree that PI3 kinase inhibition appears to be inferior to BTK inhibition in the relapse setting in terms of progression-free survival. And this represents one of the very few head-to-head studies that we have published at this point comparing novel options. Again, looking at those subgroups, regardless of the deletion of the chromosome 17 aberration status or IGHV status, the subgroups favored the acalabrutinib arms in terms of progression-free survival. So we've spent a lot of time talking about BTK inhibitors. Let's of course discuss venetoclax, which was very exciting back in 2018 when the Murano data was initially presented at ASH, and we got the first of the time-defined treatment approaches for are novel agents where 24 months of venetoclax with the first 6 months rituximab included was compared to BR. You can see the big differences in progression-free survival. As of last ASH, they had given us a 4-year update. We still had not hit the median progression-free survival. I happen to know at this ASH meeting, the 5-year update will be presented, and a median progression-free survival has been reached. A bit over 50 months, and that data compares similarly to what has already been presented in terms of the long-term follow-up for BTK inhibitors in the relapse setting. So again, this supports the sentiment that we've really had that in terms of efficacy, BTK and BCL2 inhibition seems to be pretty similar. But when you're talking to your patients, and perhaps the priority is time-defined treatment, now with the CLL14 option in the frontline setting that's been discussed, with 1 year and stop, and now the Murano 2-year and stop approach in the relapse setting, we've got time-defined options for patients who really value that. That was lacking prior. So we've already alluded to the unique, in terms of small molecule inhibitors, the unique ability for venetoclax to induce very deep remissions. Here is the outcomes based on minimal residual disease status broken into 3 categories. We've got the undetectable, the low, and the high. So high MRD being defined as above 10 to the minus 2, and you can see that they do seem to separate out by how deep the response is. At this point, my patients want to know what we can, and of course other clinicians ask me this as well, what can we do with this information? At this point, it is not predictive information, it is ultimately prognostic. We hope to have prospective studies that look at making treatment decisions based on these minimal residual disease results. And for now, I'm giving the information to patients. Understandably, if you've got a patient with high MRD positivity, it's perhaps not the patient you feel most comfortable with stopping venetoclax treatment. But again, the data to support using it as a reactive tool is still lacking at this point. We can certainly feel reassured that the good chunk of patients that are going to get MRD negative are going to have good outcomes whether or not we stop treatment, and that should of course reassure us that stopping treatment appears to be safe in those patients. We think about tumor lysis syndrome, of course, when we talk about venetoclax, but as has already been mentioned, it's actually the myelosuppression, neutropenia specifically, that's going to be the dominant issue. I frequently use GCSF, particularly early on in treatment course when there's still a significant burden of CLL in the marrow, to help bridge me through that phase of therapy. Ultimately, I do find myself having to dose reduce due to recurrent neutropenia if it keeps happening, particularly later on in therapy. Diarrhea, infection, of course, joint pain, arthralgias. The TLS, I would just like to reassure everyone, if you follow the 5-week dose ramp up as per label, prospectively on trials, the incidence is almost 0 of clinically significant TLS when you follow that 5-week dose ramp up. So it is quite safe, although it can be cumbersome with the patients, getting them in for all that lab monitoring. Some of those patients, of course, need to be hospitalized. And back to the COVID discussion that came up earlier, it's something that is of special consideration. I like that term low touch that Dr. Thompson referred to in terms of BTK inhibitors. I have patients that are certainly considering more low touch approaches as perhaps previously prior to COVID. So now, to round out the talk, I just want to highlight a few important points by adding in some variations on our patient cases. So this is going to be the exact same patient, so I won't go through it completely. This is the patient that had previously received BR back in 2016. But what if we changed the BR and put in that the patient had actually gotten ibrutinib and had progressed after frontline ibrutinib. What data do we have there? And of course, we're moving into what we call sequencing data. For venetoclax, thankfully, that was where, prior, I would say, to Murano's approval, that we were using venetoclax primarily was in patients that were relapsing, and particularly relapsing after ibrutinib. When we get a good treatment, a good new option like ibrutinib, we're always wondering what can we do for patients that ultimately need treatment after progressing. And thankfully, to a high degree of response rate, the interventions with venetoclax seem to be effective. This was a study presented with I would say pretty impressive progression-free survival for these patients that received venetoclax in ibrutinib refractory or intolerant patients. They had received over 4 prior lines of therapy, and their response rates were still at 70%. What if we took this same patient and instead of BR, they had gotten ibrutinib but had to stop 2 years prior due to AFib? I think this is a really interesting case to discuss. Venetoclax, as was mentioned with the previous variant of the case, is certainly an option because of the data that we've presented that shows how long patients can get benefit from BTK inhibition. I do try to maximize, I should say, I try to get all the mileage out of that approach as possible. So if a patient has had to discontinue ibrutinib due to toxicity, and even if it's been a while since they've stopped, I typically will try to switch them to acalabrutinib now that we have that as an option. It's been available in the United States for a year for treating CLL patients both from frontline and relapse. And this is a nice study done by Farouk Awan that looked at if you've got a patient with a significant grade 3 plus toxicity and you switch them to acalabrutinib, how do they do? And all those small numbers, I do feel like this reflects my clinical experience that the majority of patients are able to resume treatment with BTK inhibition with acalabrutinib and do not have the toxicity occur. And on this study, 72%, the toxicity did not recur at all that led to their discontinuation, and on another 13%, it did recur, but at a lower grade, and those patients were able to continue therapy. So overall, 85% of those patients were able to continue on treatment with BTK inhibition without and still get the benefit from long-term BTK inhibition. These are a list of the various different grade 3 plus toxicities on that trial, and those that did and did not recur when they switched to acalabrutinib. And then finally, the final variant that we'll discuss with this patient. What if this was a rare patient, perhaps on a clinical trial that had seen venetoclax frontline and has already progressed? What do we do with those patients that now require treatment? And again, back to the sequencing data that we do have, this is looking into real-world data to help power these decisions. It's from Anthony Mato and the CLL Outcomes Consortium. So we looked at progression-free survival in patients that were BTK naive that had progressed on venetoclax, and you can see that BTK inhibition does seem to work after venetoclax, just like venetoclax seems to work after BTK inhibition. Obviously, not surprisingly, if a patient had seen BTK and this was notably both frontline and relapse patients, and it's going to be enriched in the relapse setting. If patients had received BTK previously, then seen venetoclax, they did obviously better if they had come off BTK previously for a toxicity issue. If they had progressed on BTK inhibitor, they didn't see much response when a BTK inhibitor was then again sequenced in following venetoclax. I hope I've been able to highlight that with these small molecule inhibitors, these high risk and relapsed CLL patients have seen their outcomes significantly improve, and thankfully, by and large, the long-term toxicity data would indicate that the majority of these patients tolerate these therapies quite well. We'll see what combinations can do for this relapsed refractory patients in the future, and again, maybe additional exciting interventions like CAR T-cell therapy in this population will be interesting to discuss in future ASH updates.
Well, thanks, Ryan. I have to say I completely agree with your approach about looking to stay with the same line of drugs wherever possible. Of course, you're absolutely right talking about intolerance. So clearly, if a patient is resistant to ibrutinib, they're going to be resistant to acalabrutinib also by the same mechanisms of action, we believe, so probably not useful there. But certainly, it's useful in terms of the toxicity profile. And I'm looking now at a whole variety of more questions that are coming in from the audience. And again, a lot of them look at the combinations of doubles and triplets and the role of MRD. So I think actually what makes much more sense for us to go straight on to hear from Phil Thompson, who's from the MD Anderson, who's going to give us our final seminar on future novel combinations, MRD assessments, and CAR-Ts, which do address lots of the questions already coming in, and we'll look to have time to discuss that further on. So Phil, straight over to you.
Okay, well, thanks very much, John. In the time we have remaining, I'd like to talk about where I think treatment is going for CLL in the future, and I want to focus on time-limited approaches with combinations of BTK inhibition plus venetoclax plus or minus a CD20 antibody, how we can maybe use MRD approaches to personalized therapy, and then the very exciting field of CAR T-cell research and how we might improve upon the results that we're seeing there. The combination of a BCL2 inhibitor with a BTK inhibitor is highly attractive for a number of reasons. Firstly, clinically, we sort of see a differential compartment effect. So one of the problems with long-term BTK inhibition is that there's often residual CLL in the bone marrow, whereas venetoclax is more effective at clearing the marrow. These two drugs are both targeted therapies that inhibit a specific enzyme in the case of a BTK inhibitor, or protein in the case of BCL2 inhibitor. The most common resistance mechanisms to each are point mutations in those respective targets. Mathematically, the likelihood of resistance developing in one cell with mutations in both of those targets during combination therapy is exponentially lower than the likelihood of resistance emerging during sequential monotherapy. Now, whether that bears out in long-term studies remains to be seen, but certainly theoretically that is a benefit. Importantly, there's a non-overlapping toxicity profile between these two drugs, with few adverse events being shared between each drug class, perhaps with the exception of diarrhea. And there's the potential for time-limited therapy, particularly because of the high rates of undetectable MRD that we can achieve. Preclinically, there are several studies that have shown a compelling rationale to combine these agents. B-cell receptor signaling increases MCL1 levels, another anti-apoptotic protein that may be a potential resistance mechanism to venetoclax. And there's been in vitro synergy shown in several studies. These are data that Dr. Varsha Gandhi's group generated at MD Anderson, showing dramatic downregulation of MCL1 during therapy with ibrutinib, which you can see on the lower left here, while BCL2 levels are either ineffective or increased during therapy. And on the top left, you can see in vitro cytotoxicity data in primary CLL samples taken from patients during ibrutinib therapy. And you can see dramatic cell kill in these dark blue bars in patient cells treated with venetoclax. Similarly, Dr. Tony Latai's group in Boston has shown with a BH3 profiling analysis that BTK inhibition dramatically increases CLL cell dependence on BCL2, so potentially sensitizing cells to killing by venetoclax. So there have been several studies now that are either completed or ongoing with a combination of ibrutinib and venetoclax. I'm going to present data from the MD Anderson phase 2 study led by my colleague Dr. Nitin Jain. This study had both frontline and relapsed refractory cohorts. The frontline cohort, the patients were selected to be FCR ineligible, so by that I mean age 65 or older who may have higher toxicity from FCR, or patients who genomically would be predicted to have less favorable outcomes after FCR, so unmutated IGHV, 17p deletion or TP53 mutation, or 11q deletion. Treatment schema is shown here. Essentially, 3 months of ibrutinib monotherapy, which debulks the patients and therefore lowers the risk of tumor lysis syndrome during venetoclax dose escalation, followed by 24 cycles or almost 2 years of combination therapy, bone marrow examination at the completion of 24 months, and patients who are MRD positive would continue ibrutinib maintenance. These are the serial MRD results. This is 4-color flow cytometry, sensitivity 10 to the -4, done in bone marrow, and you can see progressively increasing rates of undetectable MRD during therapy, reaching 65% after 12 months of therapy and 75% after 24 months of therapy. Notably, also a 74% rate of complete remission or complete remission with incomplete count recovery, which compares favorably, for example, to venetoclax plus obinutuzumab therapy in CLL14, where the CR rate was less than 50%. And these are the progression-free survival and overall survival data. Importantly, no patients with CLL progression. There were two cases of Richter transformation and 3 patients who died, 2 from infection and 1 from a presumed cardiac arrhythmia. Moving to the Captivate data, and we're going to see more data from this study at ASH, which I'm looking forward to. This is a study that uses a similar approach, ibrutinib for 3 courses, followed by 12 months of ibrutinib plus venetoclax. It has 2 cohorts, one of which is an MRD-adapted design, and one of which is a fixed duration of 12 cycles of combination. The MRD-directed design is really interesting. So at the end of 12 months of therapy, patients have response assessment. If they're MRD positive, they are randomized to either continue ibrutinib plus venetoclax combination or ibrutinib monotherapy. But if they're MRD negative, they're randomized to either continue ibrutinib maintenance or to have no further therapy. And we'll see some of the progression-free survival data from that group later in the ASH meeting. So the most common adverse events are shown here. Essentially, these are they're additive rather than synergy, perhaps with the exception of diarrhea shown on the top here. But I will point out that the diarrhea is mostly of grade 1 and 2 severity, rarely necessitates dose reduction, and very rarely necessitates cessation of therapy. Importantly also, grade 3 infections, neutropenia is by far the most common adverse event of high severity, grade 3 or 4 severity. And this is not dissimilar to what one sees with venetoclax plus an antibody, or indeed venetoclax monotherapy. Grade 3 infections, despite the high rate of grade 3-4 neutropenia, were rare, so 2.4% during the ibrutinib monotherapy phase and 2.4% during the combination phase, with no grade 4 infections. The MRD data are very similar to what we saw in the MD Anderson study. 75% undetectable MRD in blood and 72% in bone marrow at the completion of 12 cycles of combination therapy. And I'll point out here that almost every patient has less than 1% MRD at the completion of 12 cycles of combination. And these are the data that we'll see some more of later on in this ASH meeting. Just looking at that group of patients with undetectable MRD after 12 months on Captivate and the randomization to ibrutinib versus placebo, no statistically significant difference in progression-free survival yet, but there are cases of disease progression in the placebo group which have yet to be seen in the ibrutinib maintenance group. So this is an important ongoing question that we need to answer is what is the outcome for patients who receive time-limited therapy that go on to stop treatment. So Don't really have time to go into the triplet combinations in detail, but there have been several phase 2 studies done with ibrutinib, venetoclax, and obinutuzumab, acalabrutinib, venetoclax, and obinutuzumab, that show very high rates of undetectable MRD, although within the limits of cross-study comparison, they don't seem dramatically different from the rates of undetectable MRD that we see with doublet of ibrutinib and venetoclax. So it's very much an open question as to whether the addition of obinutuzumab to a very potent oral doublet of a BTK inhibitor plus venetoclax makes a major difference to outcomes. There is an ongoing phase 2 study at MD Anderson that's just started looking at the combination of acalabrutinib, venetoclax versus acalabrutinib, venetoclax, obinutuzumab, the phase 2 randomized design, both in the frontline and relapsed refractory setting, that will hopefully provide some insights into that question. And there are also numerous ongoing phase 3 studies looking at various combinations of targeted agents, plus or minus CD20 antibodies, compared to either standard targeted agent approaches or chemoimmunotherapy, that I think will give us enormously important data in the coming years. So I'd like to focus in a little bit more on MRD. We know from chemoimmunotherapy studies, and we know from Murano in particular, that MRD tested at the completion of treatment, of a time-limited treatment approach, is a strong prognostic factor both for progression-free survival and overall survival. However, it's not perfect, so many patients that achieve undetectable MRD4, particularly if they have high-risk genomic features such as unmutated IGHV, will go on to progress despite having undetectable MRD4. And the reasons for this could be that they have disease detectable that's present in lymph nodes that's not detectable in blood or bone marrow. It could be that our test is just not sensitive enough to detect the residual disease. So the question then becomes, how deep should we go? Should we be looking at MRD6? And we now have the technology to do that using next generation sequencing. There's no data on MRD6 yet from ibrutinib venetoclax studies, although I know that MD Anderson samples are being analyzed. We have some data from FCR, and we have data from CLL14. And we also have some data from a phase 2 study with ibrutinib FC and obinutuzumab done at the MD Anderson. So when we looked at the most recent MD Anderson cohort of patients treated with FCR, and we took patients who had undetectable MRD4 in bone marrow at the completion of treatment, we had 62 who had stored samples at the completion of therapy. And when we analyzed those with NGS, 75% of those patients had detectable MRD in bone marrow, 45% in peripheral blood mononuclear cells, 25% in plasma. And when you looked at progression-free survival according to MRD6, patients who had undetectable MRD6 in bone marrow had superior progression-free survival. And similarly, patients with undetectable MRD6 in peripheral blood had superior progression-free survival to those with detectable disease. Increasingly, we're having more potent therapies, and particularly, I think, as we start to see some of the data coming from frontline regimens combining ibrutinib with chemoimmunotherapy. In this case, I'm showing data from IFCG study, and also with CAR T cells. We're getting to the point where we really can achieve significant disease burden reduction. You can see here from IFCG, 97% of patients had undetectable MRD4 at the completion of 12 courses of treatment. And it's questionable whether doing a test where 97% of the patients return a negative result provides a lot of information. However, when you look at undetectable MRD6, approximately half of the patients had undetectable MRD6 in the bone marrow at completion of treatment. So as we follow these patients long term, it may become clear that MRD6 testing is necessary to provide useful prognostic discrimination in a group of patients receiving a very potent therapy. These are data from CLL14 from the venetoclax obinutuzumab arm. You can see at the completion of treatment, 71%, the royal blue and the orange bar had undetectable MRD at the sensitivity of 10 to the minus 4 using an allele-specific oligonucleotide PCR. And of those 71%, just over half had undetectable MRD6, so 39% of patients in total had undetectable MRD6. And so it'll be really interesting to follow these patients for long-term progression-free survival and see which of these is providing the most useful information. But you can see with serial MRD analysis, the proportion of patients with undetectable MRD6 is shrinking over time, and the proportion with undetectable MRD4 shrinking over time, indicating that after completion of treatment, these patients are having rising levels of disease that will undoubtedly eventually lead to clinical progression. So finally, moving to some CAR T-cell data, I'm going to focus on the Transcend study using Liza-cel, which is a 1-to-1 ratio of CD4, CD8 T cells targeting CD19 using a 4-1BB co-stimulatory domain. Patients on this study had to be have either failed or be ineligible for a BTK inhibitor, and failed either 2 or 3 prior therapies, depending on their genomic risk factors. They received standard lymphodepletion with Flu/Cy, and then CAR T cells. The toxicities that I'd like to point out here are that there was a low rate of severe cytokine release syndrome, much lower than we're used to seeing with other products in other diseases like diffuse large B-cell lymphoma. But there is still an appreciable rate of grade 3 neurologic toxicity, or ICANS, that you can see there. The responses on the study are shown here, and they're really quite impressive. So looking at overall response, over 80% in the total cohort, with 45% complete remission. But I'll draw your attention particularly to the patients who are double refractory, failed a BTK inhibitor and venetoclax. You can see 67% complete remission rate in that very difficult to treat patient population, and a 75% rate of undetectable MRD in bone marrow in that population, which is remarkable in a relapsed refractory population. So what does that undetectable MRD in bone marrow mean? Well, these are data using essentially the same product that were generated from the Seattle group led by Cam Turtle. And you can see that the patients in blue who had undetectable MRD using NGS at the completion of treatment have very favorable outcomes in terms of both progression-free survival and survival. So I think this is going to be important information post-CAR T in terms of determining prognosis. So why do some patients with CLL who get CAR T do very well and others not so well? In CLL, unlike in, for example, ALL, the most common reason for treatment failure is not loss of the CD19 target. What it is probably the major mechanism of failure is I guess, unfit T cells. And this is a very elegant study that was done by the Penn group. You can see on the left gene expression profiling data taken from the apheresis product, so the CAR T product from patients, and split up according to their eventual responses. You can see here on the left that the gene expression profiling of the CAR T in patients who had CR dramatically different from those who did not respond, shown here on the right. And there were marked differences in the T cell subsets, with more memory T cells in the patients who went on to achieve CR, and also high levels of T cell exhaustion in patients who did not respond. And when they took the CAR T cells from patients who were treated on the study, or made CAR T cells from healthy donors, and then infused those into tumor-bearing immunodeficient mice, you can see that the mice who received CAR T cells from patients who achieved CR or from healthy donors had markedly better survival than the mice who received CAR T cells from patients who did not respond, indicating that there are intrinsic deficiencies in the CAR T cells from patients who did not respond to them, rather than perhaps it being tumor-specific features that lead to disease resistance. So how could we improve on the results of CAR T cells armed with this knowledge? Well, one approach that's been taken is the addition of ibrutinib to CAR T cell therapy. So we know from ibrutinib studies and looking at serial immunologic analysis that ibrutinib has several beneficial effects on T cell function in patients over time, with a reduction, for example, in T cell exhaustion. So perhaps this could make more functional T cells in the CAR T setting. These are data again from the Seattle group of a phase 2 study of ibrutinib combined with liso-cel. And you can see here, these are CAR T cell expansion data for ibrutinib plus CAR T in red compared to a historical group that did not receive ibrutinib, shown in blue. And there's no difference in CAR T cell expansion. So importantly, continuing ibrutinib during CAR T cell therapy does not inhibit CAR T cell expansion, which is a major determinant of efficacy. Secondly, and very interestingly, there's a significant reduction in severe cytokine release syndrome in the patients that had ibrutinib therapy. So you can see much lower rates of grade 2 CRS and no grade 3 or 4 CRS in the patients given concurrent ibrutinib. Efficacy seems to be excellent for this combination approach. On the right, you see most patients achieving undetectable MRD by next-generation sequencing. And on the left, most patients achieving at least a partial remission from their treatment. And with short follow-up, a good progression-free survival in general. So just to summarize, I think we can say that combinations of targeted agents are very well tolerated with high rates of undetectable MRD and CR and very few cases of on-treatment resistance. We have the potential for time-limited therapy, but it's important to say that at this stage, the durability of off-treatment remissions, particularly for patients with high-risk genomics, are unclear. And I'm really looking forward to seeing some MRD6 data that might provide further insights into the group of patients most likely to achieve long-term unmaintained remission. I think that MRD6 is likely to give us additional prognostic discrimination, as we've seen with the FCR data in the novel agent setting. And I think a big open question is, what do we do with patients who have detectable MRD at the completion of a combination treatment strategy which is intended to be time limited? Do these patients benefit from additional maintenance therapy? What should that maintenance therapy be? Should it be ongoing combination? Should it be monotherapy? And I think in this regard, the Captivate data are really awaited with interest. So thank you for your attention, and I'll turn it back to John.
All that remains for me now, of course, to do is to thank all of the speakers for their excellent coverage today, particularly to thank Terry for taking the time to come in and give us the patient's perspective. Can't stress how important the patient perspective is to your decision-making process.
Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/QUE860. This activity is supported by independent educational grants from AstraZeneca LP, Adaptive Biotechnologies, Pharmacyclics LLC, an AbbVie company, and Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC. This activity has been jointly provided by Penn State College of Medicine and PVI, Peer Review Institute for Medical Education.